Now I'm going to talk about my first cases in the Preserflo Microshunt in treating the open-angle glaucoma. Here is the first case, 61 years, male patient with IOP in the right eye 24 mm mercury, in the left eye 16 mm mercury. Cubic ratio in the right eye 0.8, in the left eye 0.6. Patient has primary open-angle glaucoma and he was using Azarga 2 times per day in both eyes. In the OCT, we can see severe thinning of the RNFL in the right eye comparing with the left eye. Left eye, there is only thinning in the inferior part of the retinal nerve fiber layer. In the visual field, we can see bilateral visual field defect more in the right eye as it's clear. I started the surgery with transcorneal traction suture using 7/0 Mersilk. Then a small snip in the conjunctiva, injecting BSS to ballooning the conjunctiva as it's clear. Then dissecting the conjunctiva. In this case, I prefer to do dissection using the dry sponge, which is very safe. You can see, using mini sponge, just go underneath the tenon. This is very safe and a beautiful dissection of the conjunctiva. We can avoid subconjunctival hemorrhage using the dry sponge dissection, as you can see. Usually I prefer to do the surgery in the superior nasal quadrant, about 2 mm away from the nasal root of the superior rectus. Then using mitomycin C underneath the tenon for about 3 minutes, 0.5 mg per ml. After 3 minutes, we can remove the mitomycin soaked sponges, followed with thorough irrigation using the BSS, as you can see. Then marking using the special marker 3 mm from the surgical limbus, using 1 mm keratome, which is a special keratome for the Preserflo. You can go about 1.5 until the wide edge of the keratome, then using a 25 gauge needle in the same entrance of the keratome, you can go into the anterior chamber near to the iris, away from the cornea, as you can see. Wide dissection of the conjunctiva is very important while implanting the Preserflo to decrease the pressure. Here, as you can see, inserting the Preserflo into the anterior chamber until the fins of the Preserflo is incarcerated within the scleral tunnel. Now I'm testing the leakage through the Preserflo. You can see, just apply gentle pressure over the eye until you can see the leakage. Look here. Now start leakage. You can see this leakage after applying gentle pressure over the eye. Now it's very important to close the tenon first over the Preserflo tube using 9/0 Vicryl suture. This is the tenon suturing, just to suture, but you can see here it's very important to check the distal part of the Preserflo before closing the tenon to be sure it is not closed by the tenon. Here is the second suture of the tenon. You can see the tenon is stretched over the Preserflo. Now it's the time to closing the conjunctiva. I prefer to use 10/0 nylon suture. to close the conjunctiva with 2 sutures at the limbal part of the eye. Here is the first suture. Then buried the suture inside the limbus. Here is the second suture, 10-0 nylon. Go through the limbal area into the conjunctiva with mini bites into the conjunctiva, as you can see. Here also you can take another suture to be sure the conjunctiva is closed in both sides. Here is the end of the surgery. You can see the Preserflo inside the anterior chamber and the conjunctiva is closed properly. Here is 1 day post-operative. You can see the anterior chamber is formed and diffuse bleb. You can see the tube inside the AC. You can see the IOP, as I wrote it, 7 mm mercury. 2 weeks post-operatively, you can see the pressure 9 mm mercury, diffuse bleb, well-formed AC, and the tube inside the anterior chamber. Let's go now to the second case. 65 years, female patient, visual acuity in both eyes 20/100. Patient has bilateral dense nuclear cataract +3 with pseudoexfoliation. The pressure was 18 mm mercury in both eyes with full anti-glaucoma medication and cup disc ratio 0.9 in both eyes. Patient has pseudoexfoliative glaucoma in both eyes. Here in the OCT you can see thinning of the RNFL in both eyes, the right eye and left eye, more in the left eye. And as you can see, there are bilateral visual field defect in both eyes and more in the left eye. In this case, you can see the pupil is small and you can see the pseudo-exfoliation. My plan was combined Preserflo with phacoemulsification. After traction suture through the superior part of the cornea, injecting BSS to balloon the conjunctiva, then complete dissection using the dry sponge. As you can see, I used many sponges to dissect the conjunctiva underneath the actinon. After that, applying cautery and mitomycin C 0.5 mg per ml. 3 sponges are soaked through the mitomycin C and inserted underneath the actinon, as you can see, followed with thorough irrigation using the BSS. Now the time of phacoemulsification, 2.4 clear corneal incision, injecting my drain inside the anterior chamber. You can see the pupil is dilated to be about 4 or 3.5 mm in diameter. Doing the capsular rixes hydrodissection, then 2 side ports are opened. Now emulsifying, this is cataract using the horizontal chop technique. As you can see, chop and emulsifying, this is cataract. Then using the bimanual irrigation aspiration to clean the cortex, as it's clear. In this case, because of the pseudoexfoliation, I prefer to use 3B hydrophobic IOL. Sometimes the haptic inside the sulcus and the optic capturing the anterior capsular rixes. Always I prefer to take suture through the main phaco incision in combined cases using 10-0 nylon. Now you can see 3 mm marker away from the surgical limbus, 1 mm special keratome, go through the sclera, Then using 25 gauge needle in the same entrance of the keratome into the anterior chamber away from the cornea, over the iris. Here is the Preserflo Microshunt, implanting the shunt through the scleral tunnel until the fins of the Microshunt incarcerated through the scleral tunnel, then testing the leakage. As you can see, sometimes you don't find leakage, just apply gentle pressure over the eye, over the groove. You can see a beautiful leakage through the Microshunt Preserflo. Then in the same thing, using 10 of vicryl suture to suturing the tenon layer first. As you can see, before suturing the second part of the tenon, you can see here the Preserflo Microshunt is angulated and closed by the tenon, so it's very important to adjust its position before closing the tenon. Here is the second suture through the tenon. Now you can see that tenon is stretched over the Microshunt, then closing the conjunctiva. Here using the vicryl 9O to do the first suture at the limbus, and continuous suturing of the conjunctiva using vicryl 9O suture. As you can see, here is the first side of the conjunctiva is closed properly. And now the same thing is done on the second side, or in the other side of the conjunctiva. Limbal suture, then closing the conjunctiva with the 9O vicryl. As you can see, here is the end of the surgery. Now stromal hydration for the paracentesis. Here the patient on 1 day post-operatively. You can see the IOP 6 mm mercury. The anterior chamber is well formed, cornea is very clear, large diffuse bleb, and the Microshunt in the anterior chamber away from the cornea. You can see the depth of the anterior chamber. 1 week post-operatively, the IOP was 5 mm, the fundus was normal, and the antechamber was well formed with posterior diffuse, beautiful bleb, as you can see. And thank you for watching.